Greetings to all. Welcome to Physio TV. So we'll be continuing with the part 2 of Dr. Ira ma'am's session. Handing over the session to you, ma'am.
Thank you. Thank you so much. So last time we discussed about how to identify potential risk in children who were premature. So today we are going to talk about children who are born full term, and especially we'll focus on children with 0 to 3. What all assessments we should do and how to do proper screening. Okay, so the process is like early intervention screening. So if there is a delay, then you do proper evaluation by the team. You start the intervention by the team. If there's no delay, then you send the child away and you ask them to come for follow-up. We have already discussed the guidelines for follow-up. So if the children who have a medical issues like children with spina bifida, children with brachial plexus injury, or children with Down syndrome, you would definitely go for intervention. But children who are at moderate risk, who are right now achieving their milestones and look typical, but they have a moderate risk of delays, then you will call them for follow-up at uh, 6, 9, and 12 months of age, and then 6 months thereafter. Next slide, please. So all intervention is usually done by the team. We all have discussed that what all members should be included in the NICU team. Early intervention can also be provided by the team in the natural environment like home settings. So there is a quite a few positive evidence of treating children in their natural environment, which is more common than not their home. So they're more comfortable, they're more receptive of therapies at home. So there is a lot of potential of treating the children at their home. Then you can also coach the family and do certain stimulation activities, get the stimulation activities done by the family. That's one way of improving bonding between the children and their family. So early intervention, newer research also shows that involving family and family coaching models also have greater benefit than treating them at therapy centers. And the children who are neurologically or typically have already diagnosed them, then they benefit with the whole rehabilitation team, and then you can get them to OPDs and treat them there also. Next. So what are you going to do from 0 to 3? First, you're going to obtain the history, relevant information through interview of the parents. Then you also do other systems review, like you want to see their vision, their hearing, their oromotor function, how they are doing feeding, like if they're breastfed or formula fed, how is their suck swallow, all those things you're going to review. You're going to see also at their GI system, because a lot of children with reflux might have neck tilts. So if there's some child with torticollis you're seeing, then you want to rule out the gastroesophageal reflex. Then if you're seeing a child with torticollis, you also want to rule out if they have any visual issues. So they're more common than we think. So a lot of children with torticollis might have some underlying visual problems. Some hearing issues also. If there's a fluid in the ear, then they can have neck tilts. So all those systemic review systemic review is very important. Then when you get to the motor system examination, you're going to see their tone. The neonatal reflexes are assessed for the first year of life. So if the child is 1.5 months, I might not assess the reflex. If there are some persistent reflex, of course, I'm going to note it down. But neonatal reflexes must be checked for the first year of life. Later on, depending upon the condition of the child, you may or you may not see them. Then you also check their postural control. Postural control in supine, in sideline, in prone, in sitting. It is important to check the protective and equilibrium reactions in sitting and in standing. Once they're able to stand, you are going to see all the gross motor and fine motor milestones. Then you are going to do a standardized screening tools like AIMS, Bailey, PDMS2. There are a lot of batteries which you can use. We are going to talk more about those in the later slides. Next. So neonatal reflexes at birth are rooting, sucking, gag, extrusion, or tongue thrust and cuff. So the child is born with these reflexes. Next slide, please. Then grasp, Moro's, TNR, trunk innovation, stepping or walking, parachute, and walking. They will emerge. These are the reflexes which are present in the first year to like 0 to 1, and they appear at different age times, and they kind of integrate. And integration is one of the important factors that tells you the maturity of CNS. So certain reflexes should appear and then they should integrate. Certain reflexes should persist, like parachute should persist. Parachute once is present at 6 months, it persists throughout the life. Walking reflex is there for the first 4 weeks of life and then it integrates. Then gallant and trunk incurvation you can see at 6 months and then it integrates. The tonic neck reflexes are two ATNR and STNR, and ATNR emerge at birth and it kind of integrates by 3 months. Then Moro's is in intrauterine life. It starts at intrauterine life and it integrates between 4 to 6 months. Then grasp is present for the first 3 months of the life, and then the voluntary grasp gradually develops. So this is in short about the neonatal reflexes. Next. Next slide, please. Okay, so if I have to screen somebody in 5 minutes, these are the reflexes I'm going to concentrate on. One is the walking reflex if the child is of 1 month old. Then positioning reflexes like ATNR and STNR if the child is anywhere between 1 to 4 months. Landau if the child is between 5 to 8 months. Parachute reflex if the child is 6 months and more. Protective reaction to the side at 6 months. Front at 6 months, side at 9 months, and back at 10 months, and pull to sit from 2 months onwards. So all this will give you a lot of information about their central nervous system. These are very important reflexes to check, and that they give you a lot of prognostic value to your evaluation. Also, you can decide that how their CNS is functioning, how their postural control is, how much therapy they might require, where to start, what functional goals you're going to set. For example, if somebody is having persistent ATNR at 5 months, I'm sure that he's not reaching to midline. He will not be able to roll over. So these reflexes give you a guideline that what the child is able to do and what goal you are going to set in your early intervention. So if I have to pick up from all the neonatal reflexes, this is the list I would go to and perform those, and that will give me the direction for goal setting and also the involvement of central nervous system for that particular child. Next. So this is a child who is 4 months old. I have the permission to share the picture. This child is doing well now. He look at him at 4 months of age. The ATNR posturing is still persistent. So by 4 months, the child should not have ATNR even once in a while. So it should integrate by 4 months. So if the child is 4 months old and is still showing ATNR, that is kind of alarming. So you're going to keep that in mind. Next. So next is Landau. So in Landau, you hold the baby in prone position under the chest and you suspend them and you see how their neck extension is and how their lower limb extension is. So in the first, you can see that the child is nice into extension. The head is extended and the legs are also fully extended. The arms are also extended. And in atypical Landau at 5 months, you can see the legs are still in flexion. The head is extended, but the legs are still into somewhat flexion. So this particular reflex and all other reflexes are going to give me some idea that whether the child is lagging behind somewhere, and then you can make a note of it. And depending upon all your positive findings, you can recommend whether you want to go for early intervention screening, full evaluation, and early intervention, or you want to keep the child on follow up. Next, please. This is another important test which I usually perform. One is pull to sit. So First one is the pull to sit at 3 months old. So see, at 3 months old, only the child is able to pull his or her neck in alignment with the body. So it is very important to check this. In the next picture, you see that child who's 4 months old is kind of a little atypical. He has a lot of head lag. He's not able to do neck flexion. So that tells me the child probably has low tone and is having difficulty in holding the neck. The child will probably not be able to roll over at this point of time. So pull to sit is going to give me a lot of information. So this is one test which is very easy to perform and is very quick to perform and gives a lot of information to you. So there are standards for pull to sit, that at 0, how the neck head lag should be, at 3 months, how the head lag should be, at 5 months, how the head lag should be. So by 3 months, the child should be able to hold the neck in alignment with the rest of the body for more than half of the range. And by 4 months, typically the child should not have any head lag at all. So if you see at 4 months the child has severe head lag, then that is alarming, and you will probably check for other things and recommend early intervention for the child. Next slide. This is another. So now you're done with the reflexes. Now you want to check their range of motion and their tone. So when you check, these are two important angles you check for the children from 0 to 1. So first is the adductor angle, that tells you the level of spasticity the child has or the hypotonia the child has. So for 0 to 3 months, the adductor angle should be between 40 to 80. And by 3 to 6 months, it should be by 70 to 110. For 6 to 9 months, it should be 120 to 150. And from 9 to 12, it should be 130 to 150. So if that adductor angle is less, that tells you that the child has hypertonia and you are not be able to go into full abduction. So it is important for the child to go into full abduction. If he's not able to do that, then you can say that there is a hypertonia. So this is one of the angles you have to measure. This is Hamiltonson angles test, and then the another angle you have to look at is the popliteal angle. Popliteal angle is when you flex the hip to 90 and you try to extend the knee. So that angle needs to be from 0 to 3, it should come between 80 to 100. For 3 to 6 months, it should come between 90 to 120. For 6 to 9 months, it should come from 110 to 160. And by 9 to 12 months, it should be 150 to 170. So that almost full extension should be possible by the end of 9 to 12 months. So again, if this angle are less at various ages, if they are not meeting the range, that means the child has hypertonia. And if the angles are more than this range, then you kind of know that the child is hypotonic. Next. These are some of the red flags as per the American Academy of Pediatrics. So if you see a child directly at 9 months and what the child should be able to perform, so you're going to look at 5 things: that he should be able to sit with support. There should be motor symmetry, that there should not be asymmetry. The handedness or the dominance come by 3 years of age. So for the first 3 years of the life, the child should be able to use both hands equally. So if there's any kind of asymmetry or handedness, that is kind of alarming. You have to then intervene. Child should be able to grasp the object, transfer the object from one hand to another, and child should be able to roll over on both the sides. So if any of this is not present at 9 months, then you would definitely want to go and do a detailed assessment and evaluation to know what's really going on. So it's very simple to test it. These 5 things can be tested even in 5 minutes. So if you are doing early intervention with a team, then you can just assess the child in 15 minutes tops with all the neonatal reflexes and these signs of fine motor and the gross motor things. So if you find anything alarming, you can do further objective evaluation using standardized scales. At 18 months, the child should be able to stand, walk independently, should be able to grasp and manipulate small objects. Or if you see any kind of regression. So regression is what that the child achieve the motor milestones and then later on he's not able to do it. So for example, if the child has achieved rolling at 5 months and now that he's 8 months is not able to roll, that is not a good sign. That is called as regression. So if the child goes into regression, that is again alarming. That kind of definitely tells you that something neurological is going on. If there's a persistent drooling at 18 months, for the first year of life, drooling is okay. But at 18 months or more, if the child is still drooling, then that is a little alarming. Then you want to know how the oromotor function is, what other functions the child is able to do, how is the fine motor thing. So you have to then do the detail assessment. So these are very simple five things and four things you can actually assess in 5 to 10 minutes to come to a decision that whether you want to do a further standardized assessment and which domain you want to assess. Next. Protective and equilibrium reactions we talk about. So protective reactions are when you push the child gently. Then if you give a push from backwards direction, then he should be able to extend the arm and prevent the fall forwards. That comes usually by 6 months of age. Protective reaction sideways comes by 9 months of age, and pull to sit also gives you a lot of information about the postural system and the balance. Next. We already talked about pull to sit. Next. Then once you know, if you think that there's something wrong with the neonatal reflexes, if you think that the movement and tone are atypical, then you would want to go for objective assessment. So what are the scales you can use? These are some standardized scales which we can use. One is GMFM. Gross motor function measure can be used from 5 months of age. You have to start it by after 5 months of age. Pele, you can start at 0 months. PDMS2, you can start at 0 months to 5 years. Then BOT also you can start from 0 to 5 months to 5 years. So these are all the standardized and norm reference scale which you can use. GMFM is valid and reliable, very easy to use, and it's a free scale. And others are kind of paid versions, but GMFM is free. So once the child becomes 5 months old, then you can use this scale, which is kind of free. Next. Then you can do functional assessment using VFIM if the child is more than 3 years old. If you can do PEDI, then you can do pediatric quality of life inventory. So these are scales which can give you how the motor function or the fine motor function is affecting their function and what kind of intervention you want to improve their quality of life. So these are the scales which you can use for a functional assessment once you have already found out that the child has delay. Next. Then once you know that there is you have done the neonatal reflexes, you now have the history, you have done the objective assessment of the child using certain scales, then you come to the aims and goal setting of your early intervention. So as a therapist, you're going to aim at achieving function. So that can be identified by the child if is older, or the infant or child's parents and caregivers, or specific members of the infants and child's team. You will set a short-term goal for 3 to 6 months and long-term goals for 6 months to 1 year. That is one very important aspect of early intervention. And usually the team has to be there on board for goal setting. For example, if the child is not able to sit by 6 months, then the occupational therapist will have her own goal that the child will be able to say do transfers of object from one hand to another when the child sits at 6 months. Or you as a therapist can have a goal as a child will be able to protect his fall in the forward direction and sit independently for say 20 minutes. So having those EI goals which are interdisciplinary or transdisciplinary really helps. So early intervention in a nutshell is very crucial, and it is not a one man's job, it's a team. So the more members you have on the team, the better outcome you're going to achieve for your child. The earlier you start, the better it's going to be. Assessment is very crucial, and screening is really essential because a lot of times the children with moderate risk of potential delays are missed, and when they come to rehabilitation, the window is already lost. So the whole assessment thing I have tried to cover in very short time, but it's very important to start very early, and screening is the one of the important things to do for the children. So whenever you get a chance, you have to uh, keep screening children and keep calling them, so that you will not miss the opportunity to change the trajectory of their disability. So with this, I would want to end the part 2 of my assessment lecture, and would like to thank Sanchati for giving me this opportunity. Thank you so much. If you have any questions, I'm here.
Thank you so much, ma'am, for such an amazing session. I think I had few queries actually, but as the session went along, all of my queries got already solved. So I'm falling short of questions, ma'am. On behalf of Sancheti Institute for Orthopedic and Rehabilitation College of Physiotherapy, I would like to thank our chairperson, Mrs. Manisha Sangvi ma'am, and Dr. Apurva Shimpi sir, our principal, for giving us this opportunity. Last but definitely not the least, our speaker, Dr. Ira ma'am, for taking us time and giving us such an insightful talk for today's session. Thank you so much, ma'am.
Thank you.